Hi friends, this is Dr. Apurv and with me is Dr. Harpreet Singh, and we're going to take you through a journey of Tendoachillis Tear, its diagnosis and the management. Remember, the Tendoachilles is one of the strongest tendon in the human body, and if you happen to see the movie called Troy, right, there Achilles was one of the characters played by Brad Pitt, which became very famous, that he could only be injured or killed if you strike this tendon at Tendoachilles. Achilles tendon is very commonly injured in sports persons, and you can see in this image here, we have tried to show the area where it's commonly injured. It's not injured usually at the site of insertion. It's about 3 to 5 centimeter above the insertion, the area which is also called as a watershed, because the blood circulation goes in the opposite direction and it is very prone to undergo micro damages which repeated trauma can precipitate into a tear. So Dr. Harpreet, the usual history will be a sports person.
Yeah, usually it's a sports person or maybe a elderly person also, where there may not be history of trauma in those patients. So maybe a degenerative tear in elderly patients, and usually there is a patient may have a snapping sound. He may hear a snapping sound, and after that he has great difficulty in walking. So a traumatic tear or a non-traumatic tear.
And in fact, I was reading some day back, the commonest sports associated with this injury is badminton. They say that the majority of the cases are being reported in the badminton players worldwide. And even in my clinical practice, because I practice just next to a sports complex, it has happened many times that in the evening shift of badminton, the players will come to me with a snap, palpable gap, history of sound, and they are not able to walk. They characteristically complain of difficulty in going up and down the stairs or jumping and running any sports activity, but practically they come limping to us.
Yes, that's
And
right.
then you will see that sometimes they have been treated elsewhere, and you can ask them whether they have been treated with a cast or a support, and was there any supplementary treatment given to them, and was he able to walk after the initial trauma or the snap that they heard.
So another important history I'd like to say that sometimes they have a history of posterior heel pain, past history of posterior heel pain, for which they may have taken treatment. Even some injections may have been given to them. So it's important to know that steroid injections into the tendon can lead to a or precipitate a tear in the tendon.
Right. So means this is an iatrogenic created focus that finally develops into a tear. That is what sir is mentioning here. And obviously, anything that we do in musculoskeletal system, you need to take the history of diabetes mellitus, the gout, the inflammatory arthritis, and as commonly told, trauma being the principal indicator in such a case of Tendoachillis tear.
Yes.
Right. And then the examination, you will have limping,
Yes.
and there can be a wound at the site if it's an open injury, and there can be any evidence of infection if we are ruling out.
So as we go in inspection, always start with look, feel, and move. So inspection, you have to look at the attitude and any scars. If there is a any scar, any site of signs of infection, locally raised temperature, redness, all that you have to look.
So whenever you have anything around the ankle, the position of comfort of the ankle is slightly equinus. So this is a passive position. It's not an active position of plantar flexion that the patient keeps, but we often see that the patient keeps it in that position to put that tendon into that position, because in fact dorsiflexion stretches that area which a patient will avoid and plays the position and comfort. So this is a limp in attitude of plantar flexion of position of comfort of the, for example, in the hip joint you have flexion, abduction, externation. In the knee you have slight flexion. Similarly, at the ankle, the comfort position is a plantar flexion. That's how it keeps it. And on palpation, we always start with the back of the hand to see the local temperature. Look for any warmth. We will always palpate for the tenderness. You can also, in a because it's a subcutaneous tendon that you have, you can palpate for the gap, as you say, to look at the continuity of the tendoachilles. And you can also mention the area above which it is on the calcaneal insertion of the tuberosity at the back, you can measure out where exactly the damage is. And if there is no gap, it may be a heel tendon by the elongation. And you can also compare the dorsiflexion angle, because the tendoachilles is like a strut at the back of the ankle, which will restrict the amount of dorsiflexion a patient can have, and its tear will increase the dorsiflexion that a patient gets. We are talking about the passive movements here, and obviously, as you said, look at the sinuses and the scars, which you can see whether they are adherent or not adherent to the underlying structures.
Yeah, so important thing to note in palpation would be two things: a palpable gap, look for it, and second is when you're looking at movements, passive movement of dorsiflexion would be increased on that side. I think that those are the two things to remember.
Right. And then acute Achilles rupture can be detected on physical examination with ease. Plantar flexion of the foot is understandably weak because it is the chief plantar flexion of the ankle. It is best examined with the patient kneeling and the feet hanging over the edge of the chair. And in this position, the soft tissue hang of the Achilles is like a tent ridgepole, and defects can be readily visualized. There is a visible defect in the Achilles tendon, which is very clearly seen, and this is accompanied by the swelling due to peritendinosus hematoma or in the acute injuries, which can be visibly palpable.
Yeah, so hematoma would be only in acute injuries, not in a chronic tear. So yes, in acute injuries, look for a hematoma and look for strength of the Achilles tendon, and do grade it according to MRC against gravity with eliminating gravity, and tell it in your examination findings.
So this is one of the classical tests, the Thompson test. And with the patient in the prone position, you flex the knee and squeeze the calf. If the tendon continuity is present, you will have a plantar flexion of the ankle against the gravity is positive.
So look at the position. It's the feet is hanging outside the edge of the bed. So you have to keep this position and then do a squeezing of the calf, and then look at the movements of the. So first do on the normal side. Show it when you are showing it to examiner. Show it on the normal side, then on the affected side.
So all the clinical examinations, they go like this only. And then you can ask the patient to stand on the tiptoes for raising the body, which tells about the plantar flexion force of the ankle. And obviously, in a Tendoachillis tear, it will not be possible. You can put a needle test in which you put a 25 gauge thin needle into the proximal segment and perform a passive ankle movement. If the tendon is continuous, the needle will move, and if it's not, you cannot transmit the movements into the proximal part of the tendon. And then you have the Matlis test. Patient lies prone with the knee flexed to 90 degrees. Normal test shows ankle in plantar flexion. Dorsiflexion of the ankle indicates rupture tendon. Yeah. So you can see that this side has got a dorsiflexion. So there would be a rupture tendon. This is a normal side. And because as I told you, the normal position of the ankle is plantar flexion at rest. That's how they keep it. And when we talk about the movements, now we're talking about the active and the passive movements, both painless or pain-free, accompanied by spasm or not, or crepitus or not. You can confirm the movement of the ankle and also the subtalar joint, and do mention about the distal neurovascular deficit.
Yeah, it's important. So a patient with a chronic tear may be able to do some amount of plantar flexion. So you have to remember there are other muscles also which are helping in plantar flexion. This is the main muscle, but you have other posterior tendons like tibialis posterior which help a bit in plantar flexion also. So there may be some plantar flexion. Your examiner may ask which all tendons are there. So you have to remember that. And when you're doing a heel raise test, do a single heel raise first on the non-affected side, then on the affected side, so that you are again able to compare.
Right. And then one of the primitive investigations, it's a clinical diagnosis, but then one of the primitive investigations is ultrasound, which is very good for the tissues which are subcutaneous, soft tissue structures like a tendoachilles and the muscle that you can do. You can on an X-ray see a flake of bone if it is an avulsion injury of tendoachilles. In the soft tissues, you can see a black shadow in that area, but then difficult to appreciate. MRI, I believe, will be a good investigation to tell you a tendoachilles tear. Like here, you can see this is the area where the tendoachilles.
So if you have a good ultrasonologist, he can tell the tear on us ultrasound easily. So